from the University of Kansas Health System.
I am amazed. The team here is great.
I came on a Tuesday, and then by Saturday I had a heart in me.
I have never seen a group of people work together so good as this team of heart specialists. I mean, it's just unreal.
Stand by to set up show.
And the Dolph C. Simons Jr. Family Broadcast Studio.
Roll it.
Always makes you feel like you're the most important patient on the planet.
I felt heard, and that was really big.
This is All Things Heart.
Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. Today's guest has a rare blood disorder that caused his heart to fail, and he needed help that only a few places across the whole nation offered. He found it right here at the health system and at the University of Kansas Cancer Center as well. We love your questions. Make sure to send them in to us on the YouTube, the X platform, Facebook, and the All Things Heart email. We're everywhere. You can find all the links to connect with us right now, right here on your screen. Now to Gene. Doctors kept a close eye on Gene Taylor after a cancer diagnosis, but it was a different disease that was slowly killing his heart. Janine Kiesling shows us what it took to save his life.
Thank you.
Smiles and laughter filled Gene and Debbie Taylor's home when granddaughter Isabella visits.
Very energetic, she
Yes.
This rambunctious 3-year-old keeps the Taylors busy, and that's exactly how Gene prefers it.
He's always been energetic and wanted to do something. Because look at this house. He built it. So concrete work, everything, plumbing, wiring.
Even a 2017 bone marrow cancer diagnosis couldn't keep Gene down.
Every 3-4 months we'd do bone marrow and blood tests and just kind of keep an eye on it. And everything was pretty good.
But things took a turn in late 2020. His oncology doctors at the University of Kansas Cancer Center sent him to heart specialists at the University of Kansas Health System.
He was just about to walk me out the door with a clean bill of health. And then he got to reading through my chart and asked me a few silly questions, and then he said he wanted to do another test on me. And it came back that I had amyloid of the heart.
AL amyloidosis can affect the heart, causing it to become thick, stiff, and weak. Gene learned his heart was failing. Even worse, because he had active cancer, Gene was not eligible for a heart transplant. For the next 2 years, he would undergo chemotherapy with his failing heart. It was grueling. The once active Gene spent most days in bed. Finally, in November of 2022, Gene and Debbie got the news they'd been praying for. His body's positive response to the cancer treatment meant doctors could move forward with a heart transplant.
I'm very thankful for that place because I honestly don't think, without some of the doctors, I don't think I'd be here.
The doctors and nurses and everyone at KU are just phenomenal.
Within days of the news, there was a new heart beating in Gene's chest, giving him his life back and giving his family their husband, father, and grandfather back.
That's what life's about. Family and friends, and enjoy yourself.
We are so happy to welcome Gene Taylor and his wife Debbie to today's program. Gene and Debbie, we know you wanted nothing more than to see your doctors in person, but they're battling colds today. Gene and Debbie are, so out of an abundance of caution, we're going to keep everyone separate. Thank you for being here. How are you feeling, Gene?
Quite well, really, for what I've been through.
Good.
Every day is good. It's a blessing.
And Debbie, how's the cold?
We're getting there. It's a little bit better.
Right. A little bit better. And here in the studio, I am joined by quite a cast. Okay, we've got some credentials I'm going to rattle off here. We have Dr. Zubair Shah, the director of the amyloid program here at the health system, Dr. Matthew Danter, who is Gene's surgeon, and the surgical director of cardiac transplant and mechanical circulatory support. And we have Dr. Joseph McGuirk. Dr. McGuirk is an oncologist and also the division director of hematologic malignancies and cellular therapeutics, as well as the medical director of blood and marrow transplant. If anything happens, I want you guys in the room with me. This is a very safe cast to have. Thank you for making time to be here. We know you're very busy. Gene, I want to get right to you with this first question. We know your new heart is doing well. You're still receiving some cancer treatment. Can you update us on how you're doing?
Well, before the heart transplant, I was pretty much tired, still am, but I can now walk a 23-minute mile and don't bother me a bit. But you know, I still got problems, but I'm getting there, and it's been a blessing.
He's such a go-getter, Debbie. I mean, he built your house. Just to name a few things that Gene has done. You watched your partner, Gene, undergo chemo with a failing heart. What was that like for you as a wife and a caregiver?
You know, it was very difficult for me, our family, our children, to watch him go through this. The decline in daily activities that he was able to do, in breathing, in walking, and it got to the point where he couldn't even walk up or down our stairs, couldn't walk to the mailbox. So that was difficult. And then knowing that he was on a transplant list and hoping and praying that he was able to have the ability to get a heart as we watch him decline.
Dr. McGuirk, I want to ask you, you're not Gene's oncologist. Go on, Debbie, what were you saying?
No, it was just very difficult, very tough, so.
I'm sure. Dr. McGuirk, you're not Gene's oncologist, but talk to us about his cancer and what are the odds that the bone marrow cancer could come back?
So we would expect the bone marrow cancer to come back, to continue to be present, but controlled currently. Amyloidosis has historically been considered an incurable disease. However, we've quadrupled the survival since I started out in the field in 1990 for patients with amyloidosis, and there are extraordinarily promising therapies that are currently being employed. Stem cell transplant, taking the patients, collecting their stem cells, freezing them, giving them intensive chemotherapy to kill off the cancer cell, which is called a plasma cell, makes an abnormal protein, and that's what gets deposited in the organs like the heart, the kidneys, the lungs, and other tissues, intestinal tract. We want to knock those cancer cells out. Currently, Gene's receiving a medication that binds, it's a therapy that binds, it's an antibody to the plasma cells and helps them be eradicated. But we are still looking forward to a stem cell transplant. Gene hasn't met me before, but I know a lot about Gene because I've been following his case, and I have meetings every week with my team, and we've been talking about Gene for a while and what the right timing for that stem cell transplant is. It has to be balanced against how things are going with his heart transplant and such. But we don't want those cancer cells to rear up, start dividing again, and start making these proteins and cause problems not just with his new transplanted heart, but other organs as well. So we have a lot of work ahead of us. It's an extraordinarily promising time. And one of the therapies that's being explored in early studies for amyloidosis is CAR T-cell therapy, taking his T cells out, genetically re-engineering them to attack those cancerous plasma cells, and has been highly effective in a related disorder called multiple myeloma.
Right.
And so we're moving into amyloidosis now.
Using the person's own cells to be little soldiers to go in and fight the bad guys.
That's correct.
That are brewing in the body.
That's exactly right.
Dr. Danter, the health system is one of only a few programs in the whole nation that offers heart and bone marrow transplant options for AL amyloid patients with severe cardiac involvement. What makes you confident to perform that? And why this is one of the only places that does it?
Well, surgeons are more than happy to take credit for things, but to be honest, this is largely a medical disease, and the fact that Gene has done so well is because of the very thoughtful and nuanced sort of plan that the oncology and cardiology team came up with. I feel confident in them, and I hope they feel confident in our surgical abilities to do it. But from a surgical standpoint, this is a very straightforward procedure. It's just more how do we manage him perioperatively and how do we prepare him for the onslaught of immunosuppression and then the next steps that they're going to do. And really, that's these guys. I just sew in a circle. So you're all very humble about what you do. Do you say you just sew in the circle? Yeah.
Is
that your expression?
It's still 5 circles.
You're all saving lives. I want to get to Dr. Shah because Dr. Shah, you're the head of the amyloid program.
Only the heart part.
The heart.
We have a very big amyloid program. We have a cardiac part. We have oncological part headed by Dr. Abdullah. We have a renal part, the kidney part headed by Dr. Tufaha. So it's a big
group. Team.
Yeah, it's a big team.
Which is something I'm going to get to your question in a second, but every time someone brings up working as a team, I see everybody around me vigorously nodding their head because you all have such an intricate way of working like a common, you're like one piece of machinery working together to save this patient's life. Dr. Shah, what I do want to ask you though, is it common for this to show up alongside cancer, what Gene had going on with his heart?
So as I said, we have a reasonably big amyloid program in the area, and we see most of these AL, we call them AL amyloid patients, and do extensive surveillance of their heart if it's cardiac involvement or not. Generally speaking, it's rare, it's not that common, but patients we see is common because they already have it and are referred to us.
So
it's kind of a difficult question to answer. It's yes and no.
Right.
Generally speaking, it's not that common, but at KU, since we're a tertiary center and we have a specialized amyloid clinic, so we see a lot of them.
This is in your wheelhouse.
Yeah,
this is what you do.
Yes.
I want to show some videos of, and these videos are fascinating. Also, if you're squeamish, you might not like these videos. These are videos and pictures of Gene's heart after it was removed from his body. So if you're squeamish, now would be a good time to just listen in. If you're not squeamish, it's fascinating. So let's take a look. We're going to pull up these images in the screen behind us. This is wild. I asked for some images of Gene's heart, and boy, I got them. For a normal person, a non-medically trained person like me, this just looks like a heart. What do you see here?
So looking grossly at the sample, the heart size is at least 2 to 3 times larger than a normal heart.
Because we can see a hand
also, yes,
next
compared
to
the hand. It should be size of a fist, size of a hand.
And it's much bigger than the fist.
Yes.
So that is Gene's heart. I want to ask Debbie and Gene, who are watching this as well, is this the first time you've seen these images?
No, it is not.
No, I've seen them prior.
What was it like when you saw these pictures the first time?
It was fascinating. It's actually it's cutting edge stuff, and it's just it's part of medicine. It's I grew up on farms, and I've been butchering animals my whole, so it was nothing new to me really. It was just another heart, but it was mine.
And I got to see it actually, Dr. Danter, right after being in the waiting room all day long and just sitting on pins and needles. He actually asked me if I wanted to see photos. Normally I would say no, but actually at that point I did. I was comfortable. I wanted to see what was causing the decline in Gene's health. And after seeing the pictures of his heart, I then understood why we were going through what we were going through with him. It all made sense to me.
Because you can see how thick it is.
Right. So
and how small the chamber is.
So yeah, generally the heart wall is 1 centimeter thick. That's here. But you can see this heart is 4 times thicker than normal. And that's at the cost of the cavity. As we all know, heart is a pump. You store blood, you pump the blood, you store. But there's no space for storage.
So we're supposed to see a big space in there.
Yes, I mean, only thickness of 1 centimeter. The rest, the diameter of this cavity should be 5 to 6 centimeters. But it's barely 1 to 2 centimeters. So he was not able to store blood and then pump the blood, and thus had heart failure, low blood flow to all organs.
So it was huge. It was like the size of 3 fists.
That's right.
And then
you can see he had no cavity at all. You can barely put your index finger in the heart.
It does look like, as Gene said, a piece of meat. You can't see anything when someone squeezes and then it's that is fascinating. I think it's safe for you. Well, I'll let you know if you're still squeamish when you can open your eyes and watch the program instead of listening. There you go. You're safe to open your eyes now if you're squeamish. Dr. McGuirk, I want to ask you the next question. Gene needed a heart transplant. He was also getting chemotherapy. What needed to happen after that chemo to make him eligible for a heart transplant?
He needed to have some response in his disease. We needed to decrease the disease burden. He was producing a lot of these proteins that caused that heart to thicken in the way that it did, and we needed to stop that production line so that the new heart wouldn't be immediately affected by that disease process. So we had to remit it. Now that's not the best therapy, but Gene couldn't have the best therapy, and that's represented by high-dose chemotherapy and a stem cell transplant, because those patients have a high predilection for sudden death, cardiac rhythm abnormalities, and so there's a contraindication. If they have serious heart involvement like this, we cannot do the most effective therapy of stem cell transplant. And I think that therapy will be replaced, as I mentioned earlier, by CAR-T, but those come with attendant risk and toxicities as well. And you have to make sure that that patient is going to get safely through your procedure so that they can enjoy the benefits of the treatment.
So is he considered cured, Dr. Shah, from his AL amyloidosis?
I think Dr. McGuirk will be the best one, but I don't think so. I think he's partially, he's in partial remission.
That's correct. He's in partial remission and receiving this current therapy, daratumumab, which is very effective in decreasing the disease activity. Stem cell transplant has a reasonable chance of getting him into complete remission, and in the future, that's not for the majority of patients a curative therapy, but it can buy significant time for patients with their families, years. We have patients who are out a decade and more from stem cell transplant, but inevitably the disease sneaks back up and starts causing trouble again, and that's when I believe CAR T-cell therapy will be in the commercial space and standardized for patients with amyloidosis.
So what I'm hearing you say is that this is something that Gene can live with and keep being Gene, and Debbie can have her guy, and he can be a husband, a grandfather, a dad, and keep living his life and enjoying doing the things that Gene loves doing.
That's
because
true.
of all the care and the science.
I mean, he's already a year out.
Right.
Last time I spoke to Gene, I think a few months ago, he was at a construction site.
What were
20, 30 other people.
Right, what were you doing,
They were
Gene?
doing roofing or something, I remember, very, very active. I mean, Gene's expectations are very high. You know, he will not tell you he's feeling great because he's a very active guy.
You called to check in on him and he's on a roof?
No, he was not, but he was supervising a construction site and on his feet.
We have some questions from our viewers I want to get to because we have a lot of questions that were emailed to us as well. Becca has a question for Debbie and Gene. Becca would like to know, what was the first thing you noticed after Gene got his new heart, the first change you noticed? Debbie, I want to start with you.
You know, the first thing I noticed was his breathing was significantly better. After the transplant, I thought he did exceptionally well. He was starting to walk the halls, and the transformation was unbelievable to me to go through and watch this whole process with a failing heart, a new heart, and then what that new heart has done for him and the ability for a longer life. Absolutely fascinating.
And I want to ask Gene now. Gene, I know you're battling a cold today. However, you're back to doing so many things. How soon after your heart transplant did you feel like, wow, I got my body back?
After the heart transplant, I got my life back, that's for sure. It's a slow process. The people I want to thank is the donor. Without donors, I don't exist. So anybody out there, please sign that donor card.
So important. Tommy has a question about AL amyloidosis, AL amyloid. He wants to know, how is it diagnosed? Dr. McGuirk?
It's diagnosed through doing a bone marrow biopsy on patients and tissue biopsies. So sometimes we biopsy the fat, or we can see it in a bone marrow biopsy and make the diagnosis. Sometimes we have to do heart or kidney biopsies to make the definitive diagnosis of amyloidosis. And it has classical findings under the microscope and with more deep molecular studies that we look at, and proteins that are being made and they're circulating in the bloodstream.
Is a bone marrow biopsy, do they go into your hip for that?
In the back of the pelvis.
Okay.
We go in with a needle and take a sample of the bone and suck out some of the bone marrow itself and analyze that in the laboratory.
Jeremy Yenser has a question. He would like to know, he's one of our Facebook viewers, what triggers the protein buildup that led to all this? Is it something preventable, or does this just happen to some people?
Genes in the chromosome go wrong and stop working properly, and the cell starts growing and proliferating in a way that it shouldn't normally. proliferate. It's unchecked, and those cells happen to be plasma cells, and their job in normal circumstances is to make antibodies, for example, to respond to a vaccine, or if Gene's got a cold, his plasma cells are revved up, they're making antibodies against this virus that he's dealing with right now, and that's good. We want them to do that. But once these plasma cells transform because of genetic damage, mostly acquired as we live in this world, once they start making these proteins have no good purpose. They're not fighting an infection, they're not helping protect us, and they can become deposited in the organs, such as in the heart or the kidneys, and cause real trouble for our patients, even life-threatening problems like that which Gene faced.
Yen Liang, one of our loyal Facebook viewers, has a question about breast cancer. He writes, breast cancer patients often need to undergo chemo since the breast is located quite close to the heart. Yen would like to know if undergoing chemotherapy can affect the heart's circulatory health. Which doctor would like to answer that?
So I'm a cardio-oncologist also. So breast being close to heart does not have anything to do with cardiotoxicity, only if you get radiation, because they are both in the same field. But having said that, there are certain chemotherapies that can cause heart damage, adriamycin, and adriamycin being one of them, and Herceptin being the second. So we have a very aggressive surveillance program. We do echocardiograms, biomarkers before they start chemotherapy, and keep on doing it, and generally do yearly after they are done with chemotherapy. Generally, if you use these chemotherapeutic agents, the incidence can be as high as 27%.
And as a cardio-oncologist,
yes,
one of your jobs is to monitor patients. We do
surveillance, myself and Dr. Porter does more. I am more with amyloid part, but we both contribute.
Jamie wants to know, what are the first signs of AL amyloid? What would you recognize in your body?
Patients produce too much protein, and we can see that on a simple chemistry test in their bloodstream. And depending on how advanced their disease is, they'll present with shortness of breath or with kidney problems and potentially kidney failure, increased risk for infections. So there are a myriad number of ways that these patients come to clinical attention, but there are some clues when you first see the patient to tell you what road to go down in terms of figuring out what this is.
And as Gene and Debbie said, their first sign was Gene was exhausted. Debbie was wondering what happened to Gene. He's always building things and go, go, go. Sadie wants to know, this one I'll ask to Dr. Danter, how long does it take to perform a heart transplant?
Well, of course it varies. It usually depends on whether or not the person's had surgery before from a surgical standpoint. But really, there's a lot of, as Debbie knows, there's a lot of hurry up and wait when you're planning a transplant. There are 3 lies that you're told. Basically, it's the first time they tell you when you're going to go, then the second time they tell you you're going to go, and the third time you're going to go. That's usually when you know that you can actually set the time. So for the families, they're gone for quite a extended period of time. They can be gone for 8-10 hours. It only takes about 50 minutes to sew the heart in, and then about 40 minutes to get to when you start the surgery to when we're ready to sew the heart in. And then, an hour or so afterwards to clean up, to mop up and make sure that there's no bleeding and all these other things, and the heart's working properly. So you add some anesthetic time onto that, and it usually takes about 4 or 5 hours. But the actual surgery time it can vary between 3 hours to 12 hours, depending on how bad the previous surgery was or how stuck everything was. So
how long was Gene's?
Gene's is like I said, Gene's is very straightforward because he not had previous surgery. There's no sort of dissection that needed to be done, and then so it's basically the opening time to cannulate, which takes about 30 minutes, and then sew it in for 50 minutes, and then an hour or so to do that. So it usually ranges from about 30 minutes to 3 hours to about much longer than that. But it all depends on who you're asking too, because if you ask anesthesia, it takes an hour. If you ask me, it takes the whole day. If you ask Gene and Debbie, it takes even longer. So it does vary. But the surgical aspects of it take actually less time than you might think.
Quick follow-up to that. You mentioned three false starts, or the 3 lies they tell you.
That's the joke.
What does that mean? Like, you think you're getting a heart, and then it turns out, oh, not a match?
Well, usually what it is you're coordinating multiple teams to go do this. So someone will have a delay, or there'll be a liver biopsy that needs to be done. The lung team can't get there till this time. You know, those kind of things. But basically, it's for us who take donor calls and are trying to sort things out, the whole process could take up to a day and a half. I mean, we'll start on a Tuesday and the transplant will go on
Time
Thursday.
keeps on changing.
Yeah.
Right.
You get a one time, you take them to OR, and then it gets delayed again. It's always happening.
Because you're juggling so many lives and emergencies.
Out of our control. It's in different state. And all those.
Right.
We have far less control over it than you think it would be. We can only control our end.
Sure, once you get it.
Right. So that's just the unpredictability of being a heart failure surgeon, I guess.
Boy, and it takes good bedside manner to also explain to the patients what's happening when it's so specific to their journey.
I think honestly what really helps is, and I don't want to speak to what Jean and Debbie's experience with, but we have liaison nurses that will periodically update everybody on how things are going, and sometimes that might be we're just still sitting there waiting, but they do a good job at communicating to the families because we're otherwise occupied.
Right. I want to bring everybody back in for some final thoughts from our guests. Jean and Debbie, I want to start with you as we talk about this experience and as you sit together now on this program. What would be your biggest message? Why did you so passionately want to join us this morning?
This for me, can you repeat that again? I'm a little bit deaf and I didn't catch all that question.
No problem. Why was it so important for you to join this program this morning and share your story?
For me, these doctors have gave me another chance at life. I want to thank them, but basically I just want to tell other people out there, there is hope for you. It's amazing what they can do, and if you're ever really sick, KU is where you really want to go, I will say that. And they're not paying me to say that, it's just that's from the heart. Hell of a good place.
Debbie, would you like to add anything?
I would. Something I'd like to add to what Dr. Danter said. Obviously, sitting in the waiting room was very intense during the day. The liaison nurses were fabulous. So after I got to see a photo of the heart, the other step that those nurses took, they allowed me to go into his room, use a stethoscope, and hear his new beating heart, which was absolutely an unbelievable end to the day to be able to hear that as well. And I will say, from the very beginning of this whole process, I knew that we were in the right place. We were in the right hospital with the right doctors, the right coordinator, the right nurses. It was like the whole Kansas health system was our caregiver. And so that gave us, our whole family, a peace of mind as our kids, met the doctors. And so it's been a very good relationship.
Dr. Danter, that's beautiful.
Yeah, it's really nice.
How does that feel to see a patient that's come full circle and hear those words?
Well, yeah, I mean, because of how good Jean looks, it's probably hard to point out how complicated the whole sort of medical side of his, like how thoughtful the process was up front, how much involvement was put into coming up with a comprehensive plan for afterwards. And then when you hear someone who's doing so well and being so gracious, and this is why we do this stuff. I mean, really. And thank you very much, Debbie.
Dr. Shah?
I mean, I will repeat what Jean said. I just want to send a message out there, both to the healthcare providers and patients, as being advocate for amyloid program. If you have been diagnosed with myeloma, amyloid out there, please come to us, seek second opinion. It may not be as simple, unfortunately, as some of the people out there think. So, in Jean's case, he was following with oncology outside, was diagnosed with something different, smoldering myeloma, and never knew he had heart involvement. And it was on the EKG, I saw something, got an echo, and then automatically thought this is cardiac involvement. A totally different thing.
Changed the course of his...
I mean, we have one of the best cancer centers, comprehensive cancer center, one of one of the best bone marrow transplant program led by Dr. McGuirk. So I tell all of the patients, all of the health, please refer patients, and patients, please seek second opinion. Sometimes it may be too late. I see these AL amyloid patients all the time, and not all of them, unfortunately, are fortunate like Gene. Don't come at right time. Sometimes your cardiac involvement may be too severe and not a candidate for advanced therapies.
And Dr. McGuirk, what would you like our viewers to know, and what would you like to say to Gene and Debbie?
It's an extraordinarily promising time. Gene has a lot to look forward to, statistically significantly speaking. The advances have been remarkable, and there's more to come. So there's a reason for great hope for Gene and his family and so many others who are affected by these cancers.
Well, this has been fantastic. What a great panel. And we just love sharing the incredible work that our doctors do here at the health system. But we also love giving you a little peek at what they're like outside these hospital walls.
Now for a secret look into the guardians of healthcare at the University of Kansas Health System. Let's go behind the mask.
Okay, we're going behind the mask. We're starting with Dr. Danter, who shared some adorable pictures of your kids. Tell us who we're looking at.
This is Kayla. She's the Red Witch for Halloween. This is my oldest, Maya, who is scary good at karate.
And we have a picture of a group, and I also feel like your youngest has a big day today.
Yeah, it's my youngest's birthday. She turned 6 today. That's Alyssa,
the little one?
Yeah.
Alyssa's 6?
Alyssa's 6.
Happy birthday, Alyssa. Shout out. What are you guys doing tonight? Cake, ice cream?
We already did party on the weekend, so tonight we're just doing family stuff. This is my my family and friends. We were just on a Disney cruise in this picture.
Nice. How fun. Dr. Shah, you're up next, and I love this picture.
This is Sammy Shah, my 14-year-old son.
Sammy.
He likes to play soccer.
And last I saw you, where are you here though?
Yes.
Where are you at a baseball game here?
Yes, at the Royals game.
Is Sammy a big baseball fan?
He's a soccer fan, but like sports, he's kind of a couple of inches taller than me now.
Oh, he
it's
is.
very difficult to control him, so we are in that stage. You know?
That's kind of fun.
I'm not going to say anything more than that.
It's fun for Sammy to be taller than Dad. And finally, I want to get to Dr. McGuirk. Dr. McGuirk, you have a very unique behind the mask.
Yeah. That's how I wake up every morning.
I asked for personal pictures. I got even better. I got a whole text of your whole itinerary for the day. You wake up at 3:20 a.m. every day voluntarily.
Yes, absolutely.
Why? Explain that.
I can get a lot done. I've been like that since I was a kid. I wanted to go out and play with my friends, but nobody was awake for hours after I got up. And it translated into adulthood, and it's extremely productive. It helps me exercise first thing in the morning, and so I haven't missed a day of exercise in years. I can read without interruption. I can get the work done, and I can multitask, exercise, and read and answer emails all at the same time. It's just great, and but I'm completely worthless in mid-evening.
What time do you go to bed?
I'm embarrassed to say.
Like 5?
No,
or like
about
8
o'clock.
I mean, that's still not a lot of sleep. So you're in bed by 8, lights out, up at 3:20. You're also a strict vegan.
Yes, very much so.
Explain to our viewers who aren't familiar with what a vegan is. What does that mean for what you eat?
I don't eat any animal products whatsoever, and I have an extensive family history of heart disease. And a lot of my family members at my age die, and I have high cholesterol that runs in my family. So I headed things off at the pass many years ago and said, you know, I enjoy hanging out with you guys and with my family more than any kind of food stuff I could eat. And there are pretty good data that eating a plant-based diet improves the likelihood that you're not going to have a cardiac event. So I look at that literature and I said, that's where I'm going, and I've never deviated.
What do you do? What do you eat at Chiefs games? Like if you're at the stadium.
I don't go out to just too late.
Oh, you're in bed? I love it. You know what? If that's what it takes to do the kind of work you do, that's fine. Keep waking up at 3:20. I don't know how you're still awake by 8 a.m. That's fantastic. Dr. Danter, Dr. McGuirk, Dr. Shah, thank you. Debbie and Gene, you are so amazing, and we are just so thrilled you're doing well. Hope you get over those colds. Thank you for sharing your journey with us, and to our viewers, thank you. for watching and joining the conversation. Coming up next week on All Things Heart, when her heart started pounding after suffering a terrible personal loss, she thought it was anxiety and grief. But those symptoms actually indicated a potentially deadly heart problem, likely linked to a COVID infection. That's next Thursday at 8 a.m.
Coming up tomorrow on the Morning Medical Update. How do you plan a pregnancy while also fighting cancer? I'm Jessica Lovell. On the next Morning Medical Update, meet a young mom and her doctors who made starting a family just as important as stopping cancer. Friday at 8.